organization, Sanjay Gandhi PG and Anil Bandani and Bhumika are very close friends.
Very good morning to all of you. At the onset, let me thank the organizers of this conference providing me this platform to present this piece of work. In the next few minutes, I'll be talking on the clinical impact of altered phospho-GSK3beta, beta-catenin and EMT associated markers in non-muscle invasive and muscle invasive bladder cancer. A brief introduction about the bladder cancer. We all know bladder cancer is the second most common genitourinary disease, and if you talk about the statistics, it is the 10th most common cancer worldwide, with 0.5 million new cases diagnosed every year and 0.2 million deaths reported every year as per Globocon 2020 report. Among the bladder cancer, 90% of the times it is diagnosed as urothelial carcinoma of bladder, and whereas the rest of the cancers like 9% stem cell carcinoma, 1%, less than 1% of sarcoma, lymphoma, etc. Talking about the etiology, these are certain factors which are important, which are considered as the risk factors to develop bladder cancer. For example, patients with older age are more prone to develop bladder cancer. Males are at higher risk for developing bladder cancer. Smoking or tobacco use, it increases 2 to 4 times higher risk for developing bladder cancer. Occupation exposure to mainly polycyclic aromatic hydrocarbons or benzene. So people working in rubber, dye, leather industry, pesticide applicators, painters, hairdressers, they are at higher risk for developing bladder cancer. Infections, for example, schistosomiasis or chronic urinary tract infections, those patients are also at higher risk. Certain medications, for example, cyclophosphamide, which is commonly used as a drug for cancer treatment. So if the patients are earlier exposed to this drug, they are also at high risk for this cancer. And finally, the familial cancer syndromes like hereditary non-polyposis colorectal cancer. So if the patients have this history, they are also at higher risk to develop bladder cancer. This is a cartoon representation of a hollow bladder organ. Here we can see that this disease, urothelial carcinoma of bladder, it is comprising of 2 distinct clinical subtypes, non-muscle invasive bladder cancer and muscle invasive bladder cancer. So non-muscle invasive bladder cancer, the lower stage disease, TA or T1 or TIS, it originates from diffuse red hypoplastic or metaplastic changes in the urothelium, and we can see that this tumor's growth originates in the urothelium of the bladder as a polyp-like projections. Whereas, these tumor cells can infiltrate up to the lamina propria, but if the tumor cells continue to infiltrate into the muscle layer and then perimysical fat or adjacent organs, it becomes muscle. It is muscle invasive bladder cancer, which originates from severe dysplasia or sometimes carcinoma in situ. So 70 to 80% of the times the UCB is actually non-muscle invasive bladder cancer, where 20 to 30% it is muscle invasive bladder cancer. If you talk about the surgical treatment, the resection of the bladder tumor as well as adjuvant therapies or BCG treatment, this is a common treatment modality for non-muscle invasive bladder cancer, whereas new adjuvant therapies and the complete bladder removal, these are the common modalities for the muscle invasive bladder cancer. So despite the advancements in the treatment, there is a higher frequency of recurrence as well as progression. So 70% of the times non-muscle invasive bladder cancer recur, and 20 to 30% times this non-muscle invasive bladder cancer, low stage cancer, it progresses to high stage or muscle invasive bladder cancer, Whereas if we talk about muscle invasive bladder cancer, 50% of the times it can metastasize. So it's very well known fact that the bladder cancer, it progresses and recurs at a very high rate. So because of this reason, there is a frequent and prolonged cystoscopic surveillance, lifelong is required, which makes bladder cancer the most expensive malignancy to clinically manage. There is a lack of widespread mechanism for detecting recurrence or progression, especially in high-risk NMIBC or high-grade NMIBC cases. So intensive investigation of the tumors using molecular diagnostics, this is a favorable model for urologic oncologists, and elucidating the biology of bladder cancer, it helps in the development of biomarkers for predicting disease aggressiveness, and that way it can improve the staging, detection, diagnosis, and also to predict response to specific therapies, and that way it can allow the personalized treatment plans. Genome-wide approaches and candidate gene analysis suggest that the malignant transformation of bladder is multifactorial and multitudes of genes are involved in this pathway. This is a Wnt beta-catenin signaling pathway, which is otherwise important in the differentiation of bladder layers, bladder organ layers, as well as the development of bladder organ. But if there is a disturbed or inactive, if there is an abrupt activation of this Wnt-catenin pathway, it leads to the malignant transformation of bladder cancer. So here we can see there are two figures representing the off situation and on situation. So in off situation where the Wnt ligand is not binding to the receptor, a destruction complex which is composed of 5 different proteins, adenomatous polyposis coli, GSK or glycogen synthase kinase 3-beta, beta-catenin, axin and casein kinase, it is active. So when it is active, it means that the casein kinase it phosphorylates beta-catenin, which primes beta-catenin for further phosphorylation by GSK3beta, and this leads to the creation of an active site on beta-catenin so that the ubiquitin ligase enzyme can bind to it, and ultimately beta-catenin can undergo destruction or degradation, proteasomal mediated degradation, and therefore the cytoplasmic content of beta-catenin goes down. However, beta-catenin is also one of the important markers of epithelial cell. It is a part of the desmosome. It can bind to the E-cadherin and alpha-catenin, and therefore it is helpful in maintaining the adhesive property of the cell. However, in case of on situation where we can see here the Wnt ligand is binding to the G protein coupled receptor, that is Frizzled, this binding of Frizzled to Wnt ligand, it activates a key cytoplasmic partner protein which is called D-shepherd. And this D-shepherd protein, when this D-shepherd is recruited, it results in the interaction of Frizzled with the two proteins, low density lipoprotein 5 and 6. So a kind of heterotrimeric complex is being formed. Now this heterotrimeric complex recruits axin from the destruction complex, thereby disrupting the function of destruction complex. So when this destruction complex is not working properly, the beta-catenin does not undergo degradation, its cytoplasmic content increases, and when its cytoplasmic level increases, it enters into the nucleus, where it binds to the promoter regions, bind with the T cell factor and the lymphoid enhancer factor, replaces Gaucher protein over here, and activates the transcription activation complex. As a result of this, it leads to the increased transcription and protein synthesis of number of target genes, including cyclin T1, c-MYC, or those participate in the proliferation, as well as in one of the phenomena called EMT, which I'm going to describe right now. So EMT basically it's an epithelial to mesenchymal transition where the epithelial cells they lose, they gain their motility and they lose their adhesive property and become more mesenchymal. So here we can see some of the cells which are actually urothelial or epithelial in nature earlier. When this phenomena or when there's certain aberrant activations of this vein pathway or mutations taking place, it lead to the increase in the amount of the mesenchymal proteins and reduce in the expression of the epithelial proteins. So as a result, the cells they lose their apicobasal polarity and they tend to detach themselves and gain motility. So when these cells gain motility, they invade the layers, come into the stoma and enter via the lymphatic system or into the blood system, blood vessels. Through intravasation they enter, travel a distance, and through extravasation finally come out of the vessel and establish at another site as a secondary tumor, and that's how metastasis takes place. So EMT is considered as one of the important mechanisms for metastatic spread. So in the present study, since beta-catenin pathway is well known that it participates in it leads to the malignant transformation of bladder cancer, but its clinico-histopathological implications of this pathway in bladder cancer remain largely unknown. So in our present study, we have taken up, we worked on the bladder cancer patients, both non-muscle and muscle-invasive bladder cancer, to investigate the certain key marker proteins participating in this pathway, for example, GSK3beta, beta-catenin, and marker proteins associated with the EMT pathway to check their diagnostic as well as prognostic significance. So we worked in collaboration with Department of Urology and Department of Pathology at KGMU Lucknow, and this is a piece of work on 120 patients, and these are the patient demographics listed over here as per age, gender, hematuria, smoking, tumor stage, tumor type, and tumor size. We first investigated one of the key important proteins, phosphoserine 9 GSK3beta. It is the same GSK3beta, but here the serine 9th position is phosphorylated, and this is an important implication of this molecule. This phosphorylation actually reduces the kinase activity of this enzyme. So if there is there are studies available that the aberrant accumulation of this phosphoserine GSK3beta it leads to the carcinogenic activity. We did the IHC studies to study the localization as well as the protein level of this phospho-GSK3beta in bladder mucosa, normal urothelium, non-muscle invasive and muscle invasive bladder cancer. So here we can see that this GSK3beta is abundantly expressed. Membranous expression is present in the urothelium, whereas in non-muscle and muscle invasive we could observe the nuclear as well as the cytoplasmic expression, increased nuclear and cytoplasmic expression of this protein. Here this is a percent immunostaining graph to show the percent of non-muscle and muscle invasive bladder tumors showing reduced membranous expression or no expression, or nuclear and cytoplasmic. So here we observe the muscle invasive bladder cancer showing 23.6% nuclear and cytoplasmic expression, 23.6% cases compared to 16.9 non-muscle invasive bladder cancer. Another protein which we were interested in is beta-catenin. So again in bladder mucosal tissues in normal urothelium we could observe the high expression of membranous beta-catenin, but there is a reduction in the membranous expression. In non-muscle invasive and infected muscle invasive we could observe the nuclear as well as cytoplasmic expression also. So here 15.4% non-muscle invasive showing nuclear and cytoplasmic compared to 27.3% muscle invasive. And muscle invasive bladder cancer shows the beta-catenin expression shows statistical significance with tumor grade as well as smoking and tobacco chewing status of the patients. This is a summary for the co-aberrant immunoexpression of phospho-GSK and beta-catenin in 65 non-muscle invasive and 55 muscle invasive bladder cancer. Here we could see that in non-muscle invasive tumor size and grade of the tumor showing statistical significance, whereas the grade here showing in the muscle invasive showing statistical significance with the co-aberrant immunoexpression of phospho-GSK and beta-catenin. Now, after examining phospho-GSK3beta and beta-catenin, we were interested in analyzing the EMT markers. So we checked for epithelial marker, mainly E-catenin over here, then mesenchymal and catenin and vimentin, and the rest of the 4 transcription factors, because these transcription factors named SLUG, TWIST, and ZEP. These are the important target genes for the activated beta-catenin pathway. So if these transcription factors are elevated, either at the transcriptomic level as well as at the protein level, they are supposed to participate or initiate the phenomena of EMT or epithelial to mesenchymal transition. So this is the figure for the E-catenin. Here we can see at message level there is a reduced expression of E-catenin compared to normals. This is for NMIBC and this is for MIBC, and we could observe the more reduction in the message E-catenin in muscle invasive compared to non-muscle invasive. So this is actually the bar graph which is represented, this box plot which is represented with green color. It is showing the reduced expression of E-catenin in a co-aberrant group where for both the phospho-GSK and beta-catenin are altered. And here in non-muscle invasive, we can see there is a reduced expression of E-catenin, membranous E-catenin, and in muscle invasive also the IHC scores are mentioned over here. So this is one of the representative figures. If we see the graph here, 32.3% non-muscle invasive showing E-catenin loss, whereas 56.7% muscle invasive showing E-catenin loss. These are the figures for the N-catenin, which is a mesenchymal protein or a marker of a cell which gains motility, which has high motility. So actually this protein is normally expressed in the stromal region, whereas we could observe the novel gain of N-catenin in the urothelium, both in non-muscle and muscle invasive. So we could compare these two subsets where we observed 45.2% and 48.6% of the non-muscle and muscle invasive bladder cancer showing novel expression of N-catenin. Vimentin is another marker which shows the membranous expression normally in stromal area, but in non-muscle and muscle invasive cases we observe the novel gain of N-catenin in the urothelium areas. Here 41.9% versus 51.4% expression is observed in non-muscle and muscle invasive bladder cancer. Now these are the results for the transcription factor. This one is a snail which is a transcription factor belonging to a zinc. It's a zinc family transcription factor. So one of the target genes. So here also we could observe in normal bladder or in bladder mucosa in the urothelium, we could see the snail expressing with very low IHC score. But in bladder cancer, in non-muscle or as well as muscle invasive, we could observe the very high nuclear expression with the IHC score around 200 or between 200 to 300. So here we could observe 51.6% non-muscle invasive cancer showing snail expression in a group expressing co-aberrant phospho-GSK and beta-catenin. But to our surprise, we could observe very strong expression of snail in muscle invasive, which is around 83.8%. Slug is another isoform of a snail belonging to a same family, And here also we could see the nuclear expression both in non-muscle and muscle invasive with the respective IHC scores, and 58.1% versus 72.9% cancers, non-muscle and muscle invasive respectively, showing strong expression of slug. This is another marker protein or a transcription factor twist, because these transcription factors are actually suppressing the expression of epithelial proteins, say E-cadin, and upregulating the expression of mesenchymal proteins, say N-cadin and pimentin. So twist also we observe the nuclear expression in the non-muscle and muscle invasive, and here we could see 81.81% of the muscle invasive bladder cancer showing strong expression of twist compared to 74.2% in non-muscle invasive. Last transcription factor that we studied was ZEB1. In normal urothelium or bladder mucosa, we could not observe any expression of ZEB1, but in non-muscle invasive and muscle invasive, here we can see the urothelium showing nuclear gain of novel nuclear gain of ZEB1. So in 19.4% non-muscle invasive showing the ZEB1 expression compared to 10.8% muscle invasive bladder cancer showing ZEB1 nuclear novel expression. And these are the results at the transcriptomic level. After diagnostic studies, we were interested in examining the utility of these markers in prognosing the disease outcome. So we did the follow-up studies and collected this information. Out of 120 initial patients, we could follow up only 102 patients, rest lost to follow up. And these were the informations that we collected over an average timeline of 38 months. Where the NMIBC patients, both low grade and high grade, these staging NMIBC and MIBC was on early primary diagnosis. So we could observe the recurrence both in low grade as well as in high grade, progression in muscle invasive bladder cancer. We observed the metastasis also over a period of time in 6 and 13 patients. The lymph node metastasis was observed in 13 out of 19 patients. Total deaths we observed in 31 out of 102 patients, where deaths due to cancer were in 22. And these were the stages. The patients were initially diagnosed with low stage and high stage. So to examine these expressions of marker proteins as well as the patient demographics as the independent prognostic marker, we did the Cox regression analysis, both univariate and multivariate. So in both non-muscle invasive and muscle invasive bladder cancer subsets. So when we did the one-factor analysis or univariate analysis, we observed that the smoking, tobacco chewing status, novel membranous expression of total vimentin, novel nuclear expression of ZEB1 was statistically associated with the short recurrence-free survival of the non-muscle invasive patients. Whereas altered beta-catenin, strong expression of total nuclear slug were statistically associated with the short cancer-specific survival, and the strong nuclear expression of slug was statistically associated with the short overall survival of the patient. So these are the results from the univariate Cox regression analysis. And when we performed the multivariate Cox regression analysis, all those factors which were showing the statistical significance retained their significance during the multi-factor analysis also. We also did this Cox regression analysis in MIBC subsets, and we observed that the tumor size, metastasis, altered levels of beta-catenin, strong nuclear expression of total twist, and strong nuclear expression of total slug was statistically associated with the short progression-free survival. Whereas the total altered beta-catenin, total membranous, novel membranous total vimentin, increased total nuclear slug, they were statistically associated with short cancer-specific survival. However, aberrant immuno levels of phospho-CD9 GSK3beta, total novel membranous encadering, total nucleus lung, and total nuclear snail were statistically associated with the short overall survival of the patient. So that means these all expressions or variables could be used as an independent prognostic marker for short survival probability of these patients. All these factors, parameters examined or analyzed during univariate Cox regression analysis regained their significances when multivariate Cox regression analysis was applied. Yeah, just 2 minutes. Kaplan-Meier survival analysis was finally done to check to check whether these tumors, NMIBC or MIBC subsets, showing the aberrant levels of phospho-GSK3beta, beta-catenin, as well as EMT as an independent prognostic factor. So we observed that the muscle invasive patients, which are representing with the green color, showing short cancer-specific survival probability compared to non-muscle invasive bladder cancer. However, we did not observe any significance in the excluded group, where the tumors were negative for these altered expression of these proteins. Similarly, overall survival also, muscle invasive tumors regained their, they exhibited statistical significance with short survival probability of these patients compared to non-muscle invasive bladder cancer. So what we conclude that patients showing loss of E-cadherin, gain of mesenchymal proteins and gain of transcription factors, they fail to survive within an average period of 14 months. And this suggests that the aggressiveness of bladder tumor, it could be linked to the severity of the abnormal phenotype. To the best of our knowledge, this study is the first concluding the impact of EMT via phospho-GSK3beta, beta-catenin axis on the poor prognosis of MIBC patients compared to NMIBC patients. Differences in the profile phospho-CD9 GSK3beta, beta-catenin and EMT may be responsible for observed differences in progression of the two distinct subtypes of the clinically distinct subtypes of the bladder diseases. Implications of the current findings of the study may help us to identify the subjects with a risk of recurrence or progression and worse clinical outcome after surgical resection of tumors, and it may help the urologists to propose an early aggressive therapy to them. I acknowledge DST SERB, ICMR, Center of Excellence and Research and Development, UP State Government Department of Higher Education for providing support to carry out this study. I'm thankful to Dr. Anil Mandani now and Fortes, Dr. Vinita Agrawal, Dr. Uday Pratap Singh at SDPCI, Professor Apul Goyal, Dr. Atul Singh at KGMU for supporting, for providing some certain information required to carry out this study. I'm thankful to IIT Lucknow, CSIR Lucknow for providing certain facilities to carry out this project. I'm thankful to UGC also for providing fellowship to my PhD students who did part of this work. Thank you all. In normal conditions, beta-catenin is localized to membrane part with E-catenin and alpha-catenin, so that's a normal localization. The other way is that beta-catenin continues to undergo degradation. The rest of the beta-catenin molecule should undergo proteasomal degradation, and there should not be cytoplasmic accumulation of beta-catenin. But if it is so, it enters into the nucleus. and then it binds to TCF and other target areas in the promoter regions of the genes and activate the expression of the target genes, and that's how it activates. That's how this Wnt pathway works.
Okay.